Let's delve into the fun world of cardiac. So it's finally here, the day you've been waiting for. And of course, if we're going to learn about cardiac, we always have to start with our assessment. So there's going to be a lot of stuff here. There'll definitely be some that's going to be reinforced in class. So just keep in mind, if it doesn't always make sense here, this is just kind of a foundation to kind of get you started into some of these fun, complex subjects. So who are the key players when it comes to a cardiac assessment? Well, of course, there's the heart, which is your cardiac powerhouse. Its job is to process and push blood out. There's also the blood vessels, which are your transport system. They feed all of the organs and the tissues. Even if the heart is working great, if the blood vessels have an issue and they're not, getting that blood to the rest of the tissues and the organs, it's kind of all a moot point. So, they have to work in coordination with each other. Of course, honorable mention goes to the lungs. We need that oxygen in our blood, in order to make that whole transport system even worthwhile. Also the kidneys, because they regulate blood pressure and maintain that fluid balance. And then the autonomic and sympathetic nervous system. They're effectively, kind of like our light switch. They turn on and turn off the cardiovascular system. So we're going to talk about their role as well. Let's take a look at blood flow. So during this section, it's going to be really important to understand blood flow, especially when we talk about valves and valve disorders and how things should be. But effectively, it's important to know, that deoxygenated blood, so blood without oxygen, comes from the rest of the body up this inferior vena cava to the superior vena cava and to the right atrium. And then the right atrium leads to the right ventricle, which leads to the pulmonary artery, which leads to the lungs. And then all that deoxygenated, non-oxygenated blood, it gets full of oxygen. It's ready for its next adventure. It goes through those pulmonary veins into the left atrium, down to the left ventricle, and then gets shot out into the aorta. And from the aorta, it goes out to the rest of the body. So this might seem, pretty basic stuff, but it's very important that you understand which direction stuff is supposed to move so that we know that when we're talking about some of these things, if blood's moving in the wrong direction or not going where it's supposed to go. We're going to talk about how that can cause problems. So we also need to keep in mind that in order for the heart to pump and get blood where we need it to be for this powerhouse to work, that it has its own blood supply. Yes, the heart does have its own blood supply, of course. So there are 4 main coronary arteries, and these are going to come into play, especially when we start talking about MI. But there's the right coronary artery, the left main, the circumflex, and the left anterior descending. Now these have other branches and things to themselves as well, which we're going to get into, but it is important to kind of know this because depending on where you're having a heart attack, which one of these arteries, you can have different symptoms. So it's really important to kind of get an idea of, if someone is having certain symptoms, which coronary artery might be affected, and vice versa. If someone has a blockage in their right coronary artery, what might they look like? And we're going to talk more about that. But just realize, based on where these are located in the heart, it's going to have different effects if a patient's having a heart attack. Like, for example, see that left main artery? That is all of the blood flow to the left side of the heart. And remember I said how important anatomy was in this? The left side of the heart pumps out blood to the rest of the body. So if the blood flow that supplies all of the left side of the heart, the side of the heart that needs to pump blood to the rest of the body, if that fails, what do you think happens? Yeah, usually there's cardiac arrest. This is that patient that has a heart attack that grabs their chest and falls to the ground and, kind of dies on scene. You see it dramatic in the movies. The patient, they call this the widowmaker, and they call it the widowmaker because that artery supplies all the blood flow for the side of your heart that supplies all the blood flow for the rest of your body. So, this is why these things are important. And so we're going to definitely get more into this, but it's important to understand, as much as every blood vessel that's supplying the heart is important, it's really good as the nurse to know, what it means for a patient to have a left main blockage, what it means for a patient to have a right coronary artery blockage, because that patient's going to look different. So let's talk about the functions of the heart. And there's two main functions, and these two have to work in sync with each other, because if one isn't working, the other one isn't going to work as well. So we really need both of these to work in sync with each other for optimal heart function. So first, your heart has electrical activity, and the electrical activity is used to send signals that tell the heart, hey, it's time to squeeze. So effectively, you need this. If no matter how much of a heart muscle you had, if nothing ever told it, hey, it's time to squeeze, it's not going to squeeze. So of course, if this part of the heart's not functioning correctly, if it's sending too many signals, if it's sending chaotic signals or not sending signals at all, what happens? We talk about dysrhythmias, da 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 da. So exciting, right? I know you can't wait. It's going to be so much fun when we learn about that. But there's also the fact that, it can lead to complete cardiac arrest. If there's no signals for the heart to pump, the heart doesn't pump, there's no blood flow. So speaking about that then is we also have a function on our heart as being a mechanical pump. So it squeezes or contracts to push blood forward. And how important is that? Because, it's great to have electrical activity, but if there's no squeeze, there's literally no blood moving forward. So we have to have both. We have to have the signal and we have to have the squeeze. And obviously, if our heart is not pumping blood forward, we have no blood output or cardiac output, and then we therefore have no oxygen to our brain and our tissues, and therefore we will die. So we definitely want to have both of these functions. So what affects function in the heart? And heart function, again, goes back to that cardiac output like I was just saying. And there's actually an equation. I know you guys love equations. So the equation for cardiac output is stroke volume times heart rate. So stroke volume effectively is how much blood is pumped out from the left ventricle in one contraction. So effectively, this is looking at volume, like literally how much physical blood is coming out from that powerhouse, that left side of your heart in one contraction. And then the heart rate. So how many times is your heart beating per minute? So this makes sense. If I'm trying to see how much output I'm getting from my heart, I need to know how much and then how fast. Because if my heart's pumping really, 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 really fast, it's going to affect how much blood's able to get out. And also if my heart is pumping slow, it's going to affect how much I can get out to the rest of my body. So let's talk more about some of these factors that can affect cardiac output. Let's talk about some of these factors that are going to affect cardiac output. So first we're looking at factors that can affect heart rate. So the first thing is going to be that autonomic innervation, or that on-off switch that we talked about, that fight or flight. So when we're talking about this, think about, if a bear was chasing me right now, my heart would be racing because my autonomic nervous system would be going forward. So you'd think I'd have more cardiac output, right? Because it's pumping really fast. But this is the thing. Just because it's pumping fast doesn't mean I'm getting more out. In order to effectively work, the heart needs time in between each beat to fill with blood. So even if I'm pumping real fast, I'm not necessarily getting more out because I don't have time for my heart to fill up. And so it effectively would be like taking a glass of water and trying to throw it in someone's face. But if you don't take time to fill up that glass of water, there's going to be no water to throw in that person's face. And how pointless is that to throw no water? If you're going to throw water in someone's face, you might as well fill it up with water. But it's the same with the heart. You want to be able to have time to fill, to be able to actually get that blood out. So that's something that can actually decrease my cardiac output if my heart's beating too fast, but also if my heart's beating too slow. So some people are really, they work out a lot and their heart rate's naturally lower and their body may adjust to that. But other people may have a reason. Maybe their hormones or something else, medication that they're on is affecting their heart rate and making it low. And if my heart is beating too slow, I'm not going to be getting as much out because my rate is really slow. If I'm beating 70 times a minute, I'm going to get more blood out than if my heart is beating 40 times per minute. And that's just, straight up math. The more my heart beats, usually the more I'm going to get out. But keep in mind, remember, we don't want it to go too fast. There's definitely a balance. That's why the normal heart rate is 60 to 100. Having a heart rate of 60 to 100 allows my heart to be able to push blood out, but still have time to fill in order to actually have blood to push out. So the other component of cardiac output is stroke volume. So this is all about how much volume do I have. And a lot of this is going to be talking about, you're going to hear me say multiple times, how full is my tank? So in other words, am I dehydrated? How much fluid do I have on board? Other things that are going to affect stroke volume are going to be your heart size, fitness levels, gender is different for stroke volume, your ability to squeeze, and how long it's contracting. It's a lot of those mechanical factors if you notice that there. But it's also going to be about resistance, and we're going to talk about this on the next slide about the difference between preload and afterload. But anything that's affecting the stroke volume, one has to do with the amount of actual volume that I have. So if I don't have a lot of volume, I'm not going to have a lot of cardiac output. The second thing is, how well is my heart working? If my muscle of my heart is not working, no matter how much volume I have there, if I can't squeeze well because my heart's weak, then I'm not going to be able to have good cardiac output. So this is, this second part of cardiac output, stroke volume, it has those two factors. What's my volume and what's my strength? Let's look more into preload and afterload. And if you're getting lost already, don't worry, we are going to go into these concepts more in depth in class, but this is just kind of an introduction to them. So preload and afterload are two so important things when we're talking about cardiac output and general cardiac functioning. When we talk about preload, we're effectively asking about what do we have on board already? How hydrated am I? It's the volume of blood that's coming back to the right side of my heart after it's gone throughout the entire body. So, of course, if I'm dehydrated, if I haven't been eating and drinking, if I've been vomiting, if I've lost blood, this is going to be low. If I'm in heart failure, if I'm fluid overloaded, it's going to be high. So it's all about volume. This is literally just about how much fluid do I have on board. On the other side of the heart, because that's, by the way, preload, we're talking about, usually like about the right side of the heart. We're talking about afterload, we're talking about resistance. So usually when we're talking about afterload, we're talking about resistance that the heart has to overcome to pump blood forward. And so most of the time when we talk about resistance, we're talking about systemic vascular resistance. So in other words, my left ventricle, my powerhouse, the side of my heart that's going to pump blood to the rest of my body, how much force does it have to use to get blood from where it's at out to those blood vessels? So in other words, how constricted are my blood vessels? It's pretty much saying how much pressure does my heart have to fight against to get blood out of my heart into those blood vessels. And obviously this is going to be affected by hypertension, and how many patients do we have that have hypertension? So it's always going to be about this constriction process. Effectively, if I'm trying to push a whole bunch of blood through a tiny straw, it's not going to go through very well. But if I've got a big old garden hose that I'm trying to put water through, it's going to go in a lot easier. So it's all about resistance. And obviously your cardiac output is going to be affected by both these things. How much fluid you have on board is going to affect how much you can get out, and then also how much resistance you have to fight against. Regardless of the amount of fluid you have, if you have a lot of resistance, it's going to be hard to get that blood out. So these are just two forces to consider, and they'll make a lot more sense when we talk about hemodynamics. It's coming, just you wait. So there are multiple regulators in the cardiovascular system. Now, you don't need to necessarily know these in depth. They really come into play when we're looking at all the things that can possibly, affect the cardiovascular system, how it's being regulated, how it's functioning. So, of course, we've been talking already about the autonomic nervous system, so the fight or flight, rest and digest system. So, right now I'm in fight or flight mode. I'm excited. I'm all about cardiac. I'm so excited to teach this. And you're probably more in the rest. You want to just go eat something and, curl up in a ball and take a nap. And that's okay. But these affect how they're going. So right now my heart is racing. I'm excited. I'm kind of getting, all into this cardiac mode. And you may be more laying there, kind of just relaxed. You may be getting a little more of the fright instead of flight. But either way, it's just important to know that, when we're afraid, when we feel like our lives are in danger, our body reacts. And then also when we're resting and sleeping at night, our body reacts and our heart changes its function. The heart's kind of like, okay, I don't need to do anything right now. I really need to let, the stomach just digest all the foods from the day, etc. So, you can see how they kind of take those turns. There's also baroreceptors, and effectively these are receptors within our body that respond to excess pressure or excess stretch. So the best example I can give about baroreceptors is that, that example of the fact that, you're sitting on the toilet, you're trying to have a bowel movement, you're straining really hard, you're pushing, you're like, ugh, you're trying to really, have a bowel movement, and your body senses that excess pressure. And what happens is it's like the baroreceptors are saying, whoa, 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 there's too much pressure. So they say, hey guys, we need less pressure here. So they actually automatically, in response to that, decrease your heart rate and get your blood vessels dilated or open to try to decrease that pressure. Now, while that seems to be helpful, the thing is that a lot of times this is how people pass out on their toilets, is because they have so much pressure they're straining, and then their body reacts, and then there's obviously this decreased heart rate and vasodilation, which can make them pass out. So obviously it's a imperfect system, but it is very helpful in some situations where there's too much pressure. The body just knows how to naturally respond. It has all these defense mechanisms. There's also chemoreceptors, so kind of like what we just talked about with all of the respiratory stuff. Carbon dioxide, oxygen, and pH are all regulated, but they're all regulators of the cardiovascular system as well. So as a whole, your blood vessels and other parts of your cardiovascular system adjust and adapt as like the CO2 is changing, your O2 is changing. They can constrict or vasodilate, things like that. So you don't need to know in depth yet about how that works, but just understand there's a lot of key players in how the cardiovascular system works. Whatever my heart rate is at this time, there's a lot of factors at play, a lot of different things going on. So obviously our magical blood vessels, this is where the magic happens. It's so important to just understand some of the basics about them. Blood and oxygen are great, but they're not helpful if they do not know where to go. We have to have this transport system. So the several players in the blood vessel system is going to be your arteries, your veins. When you get to the smaller vessels, you have your arterioles and your venules, and then your capillary beds. And your capillary beds are really where like a lot of the fun happens. A lot of that oxygen exchange, your tissues are getting oxygenated, everyone's happy. So yeah, and you can kind of see here in this picture, this is a capillary bed. So all of the oxygenated blood in red, it goes through the capillary beds, and then the remaining fluid goes back up through the, we call it the venule, and up into a vein, and then back to the heart. Super exciting stuff. So the difference between an artery and the vein is an artery is more of a high pressure system. So the arterioles, are very sensitive to changes in the body. So remember we were talking about those chemoreceptors, things like that. Remember all the times we've talked about the inflammatory process and kind of things opening up. This is what I'm talking about. The arterioles, they constrict and dilate in response to these changes in the body. If the body thinks there's inflammation going on, or there is inflammation, the body's responding to it, these open up to allow for more, defense things, white blood cells and all those other particles to get in. So this is like that place where these actually happen, these little small blood vessels. They start to, change. If your carbon dioxide or your oxygen levels are changing, they're very sensitive to these changes, and they'll constrict or dilate depending on what they think the body needs in response to whatever chemical is being released, or whatever if there's too much of a certain chemical. So they're very, very smart, vessels, and they have a very big role in that inflammatory process and stuff like that as well. That's going to play a big role when we start talking about sepsis and septic shock and that kind of stuff. There's also veins. Veins are a low pressure but high volume system. So you can kind of see the difference in this picture. See how thick the artery is? It has this real thick wall, very narrow place for the blood to go through. It's very high pressure, but it's got that extra thick muscular layer, and it's got to be able to open and close in response to different things. Whereas the vein is really just about getting that supply back to the heart. It's got high volume, Doesn't need a lot of pressure. It's not making all those same changes. They also have valves though, because it doesn't have that same high pressure, that same, push and muscle to it. It has to have valves in order to keep blood from going in the right direction. Because we're not, we cut them. If we're laying down all the time in a bed, it's going to be very difficult because our legs actually need a push, to get that blood that's in our veins from our feet all the way back up to our heart. These valves help with that role as well. There's also the little venules. They're the little collectors and gather, whatever they can from the capillaries, and they send it all back to the heart. So lots of little pieces here. And, you're not being tested necessarily over their exact function here, but keep in mind that all of these play an important role in a lot of the disease processes we're going to talk about. So this just reinforces that idea that I was just talking about the fact that for veins, they need some sort of push to get blood back up to the heart. So normally, for most of us, we're up walking around. So we have these wonderful legs in our muscles in our legs that are going to help push that blood back up to the heart. Whereas the patient that's maybe laying down or less mobile, they're not going to have the same thing. So these valves are really important because they help keep blood from moving backwards and collecting down in our feet. So let's get on to some more simple things. Let's talk about some questions that we can ask a cardiac patient. We definitely want to ask them if they're having any chest pain, shortness of breath. When did it start? What makes it better or worse? And we're going to talk more about, those questions that you would ask for a patient with chest pain. But that's a really good question to start with. We want to know about their history of smoking and drinking. How much, how often did they do these things? Smoking and drinking are two habits that are really hard on the blood vessels. And they can really make things very constricted, very stiff. It can cause plaque accumulation, a lot of bad things, especially smoking. Smoking is horrible for blood vessels. So you're going to see that there's a strong correlation there. So we definitely want to know their history. Any swelling in their feet, ankles, or legs may be a sign of some heart failure or their heart's not functioning properly. We want to know how many pillows that they sleep with at night. And this tells us a lot about their breathing. If they're having any problem where blood is backing up from their heart, it may make it harder to breathe. And you're going to notice this because some of these patients are going to say, yeah, I sleep in a chair at night, or, oh, I need to sleep in a recliner and sit upright in order to breathe well at night while I sleep. So you definitely want to know kind of what their sleep is like at night. Do they have to be elevated or can they lie flat? Do they wake up in the middle of the night to urinate? A lot of times this tells us about problems that they might have with their fluid balance with their heart. History of sleep apnea, because sleep apnea has a strong effect. It can cause a lot of cardiac damage. We want to know, do they wear a CPAP? Are they compliant with that therapy? And then we want to know about some of their symptoms, any dizziness, lightheadedness. Those can both strongly affect their ability to function, but also can be a safety issue. Sometimes the dizziness and lightheadedness could be from something else, but a lot of times it's because they're not getting blood flow out. But this is one of the common cardiac symptoms, especially when we start talking about valve problems and stuff like that. You're going to see this happen. We also want to know what medications they're taking. A lot of medications, and we're going to talk about them on the next slide, can affect the cardiovascular system. So we definitely want to know kind of what they have in their system that could be affecting them. Remember, there's so much that can affect the cardiac system. And then what do they do for a living? How much stress are they under? The cardiac system, of course, with the fight or flight, like right now when you're sitting here saying, oh my God, I'm never going to understand cardiac. This is a very stressful situation being in nursing school, but it's really important to know that because we can know kind of what risk factors that a patient has that might put them at higher risk for having a problem with their, towards like having cardiovascular disease problems because of that excess stress. So there's lots of medications that interact with the cardiovascular system. I'm going to just mention a few. And these are non-cardiac meds. Of course, cardiac meds are going to have a big effect on the cardiovascular system. So a lot of antipsychotics can have problems where they might cause orthostatic hypotension, which is where effectively as you're changing positions, you can get real lightheaded and dizzy because you have a major drop in blood pressure as you're changing positions. But also dysrhythmias, da 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 da. I'm going to do that every time, by the way. So there's also corticosteroids, and those can cause low blood pressure, they can cause edema, and they can also affect your electrolytes. And remember, anytime you think electrolytes, think dysrhythmias. da 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 da. All right, so there's also contraceptives. Contraceptives, like we talked about, they can lead to blood clots. They can also cause stroke, hypertension, MI. So we want to keep a close eye on patients that are taking those, especially if they already have other risk factors for these problems. NSAIDs, all but aspirin, can cause problems like MI, stroke, hypertension, heart failure. And, you know, despite popular belief, cocaine is not good for your body. Any amphetamine is not good for your body. A lot of people that come in and have heart disease, have some cardiomyopathies, have infective endocarditis are, you know, drug users. And a lot of times they love that cocaine. Cocaine is really hard, particularly on the blood vessels. It increases your heart rate. It can lead to hypertension, heart attack, dysrhythmias, lots of other problems. Tricyclic antidepressants can also cause a lot of the same problems those antipsychotics did. So if you remember back from mental health, that a lot of these medications can be very dangerous in your system. So where do we start with our physical assessment? So we always are going to start usually with taking vital signs. We want to look at their blood pressure, and we need to know, of course, what's normal. So this is a more recent, blood pressure categories. This may not necessarily match up with your book because I don't think your book was current with, the up-to-date guidelines. But effectively, we really want to look at, what is their blood pressure at baseline, just like laying in the bed comfortable. And you have to make sure you know how to take a blood pressure correctly. So you want to make sure you have the right size cuff, that they're in a comfortable position, that you didn't just have them do like run a mile or run up a flight of stairs or anything like that. You want them to be rested so that it's an accurate reading. You also don't want them to talk during the reading. You want them just to be still, legs not crossed, to try to get an accurate measurement. And so usually normal is considered about 120 over 80, but now, a lot of the guidelines are actually going to wanting it even lower than that, less than 120, less than 80. We might also get orthostatic vitals, and those are those things that I told you about, that it's all about changing positions in the blood pressure drops. So we may take their vital signs in order, first with them laying down, take a couple minute break, then we have them sit on the side of the bed, take their blood pressure, take a little break, then stand. Take their blood pressure and then see what it is. And we're going to compare because the systolic blood pressure and the heart rate shouldn't change between those. But sometimes if we're low on volume, or if we're taking certain medications, it can lead to these orthostatic changes. So we really want to keep an eye on that because that can lead to a patient to be a high fall risk, which we definitely don't want. We also need to look at heart rate, the normal 60 to 100, and less than 60 isn't necessarily abnormal. Some people, again, are athletic, they're in shape, that's normal for them, but we really want to compare it to the patient's baseline and also look at maybe if they're on any meds that might affect that. Because remember, heart rate, that's that big determinant for cardiac output. If it's too low, they're not getting enough beats per minute maybe to get enough cardiac output out. If it's too high, they don't have time to fill. So all these things are going to be important to look at. We also want to look at their oxygenation, because a lot that sometimes tells at the end of the day, are we getting oxygen out to our tissues? That tells us a lot about how the heart's functioning. Additionally, respiratory rate. A lot of times the respiratory rate changes in response to cardiac problems. So especially if it's very rapid, the body may be not getting enough blood pumped out, not enough oxygen to the system, so the respiratory rate increases to compensate. We're also going to do a very good inspection. We're going to look at the skin color. Is it pale? Is it appropriate for their ethnicity? We want to look at the neck. Is there any pulsations, any JVD? And that's that jugular venous distension, or that backup of fluid from the heart into the neck. Again, that's why it's so important to know your blood flow. What happens when blood doesn't flow forward? It flows backwards. And hopefully your blood is not flowing backwards right now after learning all of this. But it's definitely something that can happen in some of the disease processes we talked about. We also want to look at the chest, and what we're looking for there is it symmetrical? Are there any abnormalities, any pulsations that we might notice? Or is there any devices or drains? We're going to be talking about, pericardial synthesis and things like that, and chest tubes. So there might be some drains present. The abdomen, we're going to be talking about aorta problems. So is there any pulsations in the abdomen? We want to be looking for those. And then the fingers, any clubbing present, any splinter hemorrhages. And I have some pictures of those coming up. So we really want to also be looking for cyanosis. And a lot of ways we look for cyanosis is, centrally, which is in the mouth. They say central cyanosis is kind of like the blue lips, things like that, or blue tongue, like in this right-hand side, or peripheral. Maybe the tissues, the far away tissues aren't getting circulation. So the fingers, what do their fingers look like? And in people that have darker skin tones, there's different places that you can look for these things. You can look in the conjunctiva of their eye. You can look in their gum line. Sometimes you still can see them, based on doing capillary refill and things like that as well. And as a whole, we really want to be seeing how well they're oxygenating centrally and also peripherally. We also want to look at the fingers. So there's two things we're looking at for the fingers. The first thing is we're looking for clubbing. So you can see this guy up at the top. He's putting his two fingers together. You're welcome to do that right now while we're doing this. And he's doing this window test to see if he has clubbing. So you can see the tips of his nails are not touching. Now when you have clubbing, like the picture below, the picture in the center, the nails pretty much, they start to have a strange growth due to the fact that they are chronically without oxygen. So this is a sign of chronic, not lack of oxygen getting to the periphery of the body system. So you may see it in people that have chronic lung conditions and things like that as well. But this is the test that we can do for that. And then these splinter hemorrhages, same thing. It's another sign that there's lack of blood flow, but it kind of these black marks on the nail, that's what splinter hemorrhages are. So this can be another sign. It's all about oxygenation. A lot of times if the heart's not working right, that's when we're going to see these signs of poor oxygenation in that peripheral vascular system. So there's also palpation. And in the real world, we do not routinely palpate the carotids. We do not want to put pressure on there because what can happen? Of course, if you palpate the carotids, if you put pressure on them, the person can pass out. You're literally taking away their blood flow. But also if you massage the carotid because you're sitting there, because what do we do? Like, as a student, I remember those days you couldn't find the pulse. What do you do when you can't find it? You press harder. We definitely don't want to press harder, but we also don't want to massage. If you massage someone's carotid, it actually can stimulate them to have some of those baroreceptors. Remember back those pressure receptors, they can sense it and they can do strange things like drop your heart rate. They can cause you to go into dysrhythmias. Da, 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 da. There it is again. So there's lots of things we definitely don't want to do. So usually I'm not palpating anyone's carotid unless they had carotid surgery and or some sort of procedure to their neck there where I need to do an assessment of that. A lot of times you can even see a patient's carotid, pulsating without even touching it. But it's not that it's not a part of our assessment ever. It's just not usually a routine part of our assessment. There's other ways that we can see that the person's getting good blood flow. Can they talk to us? What's their mental status? Things like that, their level of consciousness. We also want to palpate for sternal markers because we really want to make sure that we're listening in the right places, especially when it comes to the heart. There's certain places to listen to, the apediment, if you remember it, the aortic, pulmonic, Erb's point, tricuspid, and mitral, listening in those right places so that you're making sure you're actually listening where you're trying to hear exactly the area of the heart that you're trying to hear. So there are certain markers, and you'll get better at kind of, finding these on patients as you do this more often. We also want to palpate the PMI, which is the point of maximal impulse. And that's that point in the heart that's closest to the front of the chest. So this is where we're going to see if there's maybe some abnormalities on. So we're going to be feeling for a thrill. Now, if you remember from learning about dialysis access, a thrill is a vibration. So if we put our hand over that point of maximal impulse, and you can see this picture is a clinician touching someone's PMI, and if they felt vibration, that could mean that maybe there's something going on with the functioning of the heart. A vibration in the heart usually is not that normal. There's also might be a heave, and a heave means like you have your hand on there and the chest wall itself is literally pushing your hand up. So this would be a heart that's maybe working really hard. It's pumping really, it's having to use that extra muscle strength to pump really hard in order to forcefully push blood out. So that can be another sign of some cardiac damage. So these are some things that we might palpate for. There's also auscultation, and some of the things we might listen for. Of course, we want to always know, does our patient have lub-dub or S1, S2? And S1 is all about the filling, and S2 is all about that ventricular contraction. Other things we might listen to is it regular? And when I'm listening to their heart sounds, is it lub-dub, lub-dub, lub-dub? Or is there other things in there? Is there lub-lub-dub, lub-lub-dub, or lub-dub, 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 lub? Lub-dub? Is it back and forth? I want to know, how does it sound? Does it sound regular? And especially if there's other sounds. Let's talk about some of those other sounds. Some of those other sounds can be what's known as S3 and S4. It's what's called a gallop, and then for the ventricle, and then S4 is the atrial gallop. And these can be signs of other cardiac disease. So if you hear an extra heart sounds, and trust me, being a cardiac nurse for years, listening to murmurs, listening to abnormal heart sounds, it's hard. And a lot of times the lungs are so loud, you can't even hear what the heart's doing. But this is something that comes with time. And as you know, a bedside nurse, you don't always have to be able to know exactly what it is, but you definitely need to know if it's not normal. So you always want to be listening for those extra sounds. You might also hear murmurs. So like, if you hear a whoosh, 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 that's normally not what you hear. You usually hear lub-dub, lub-dub, not whoosh. Whoosh means sometimes there's a valve problem. So if you think murmurs, think valve problem. And we're going to talk more about those. I'm kind of going back if there's an irregular rhythm. Remember, if there's that lub-dub, lub-dub, lub-lub-dub, lub-dub. If there's that back and forth, a lot of times we're thinking about dysrhythmias. And of course, our favorite dysrhythmia may be at play here, atrial fibrillation. You're going to know it. You're going to love it. You're going to learn all about it. There might also be a pericardial friction rub, and this kind of sounds like sandpaper, rubbing together. There also can be clicks, snaps, and other strange sounds. Again, you don't always have to know what these things are, but you definitely should try to be working on saying like, hey, this isn't normal. A lot of times what we'll do is, if I hear something abnormal, I'll have someone else listen to it. What do you think? And then, I'll kind of compare it to that and see what the doctors have been saying and stuff like that, and kind of figure out and kind of correlate that. But I always start with my own assessment. I can sometimes just start with, hey, this isn't normal. We also want to do a very good vascular assessment. So this is talking about your peripheral vasculature, your legs, your arms, making sure they're getting the blood flow and oxygenation that they need. We want to look at all four extremities, and we're looking for symmetry, color, so that's both the, if it's pale, if there's any redness, hair distribution, because when there's not good blood flow, you stop growing hair. So that's the key. If you ever want to stop shaving your legs, get really bad peripheral vascular disease. You'll have no blood flow, especially if you get peripheral artery disease. You will lose all of your leg hair, and you won't ever have to shave again. It's not the way you probably want to go about it, but it is a solution to your problem. It's just going to cause a different one. So you also want to see if you could see any edema. If there's any swelling in the extremities, it can be a sign that there's something going on with the blood vessels. There's fluid accumulating. And it also can show you a heart problem. Maybe fluid is backing up from the heart. So it could be a problem on either end. We also want to look for clubbing. Again, you can kind of see clubbing, the difference, on that left-hand picture, and any lesions that might be present. So here's some pictures of some abnormalities, the difference between a pallor and a foot and a rubor, like, a lot of blood flow or not a lot of blood flow. And here's also some ulcers. We definitely just want to be looking for these, because a lot of these ulcers are because there's a venous problem where all the blood flow is accumulating, or there's an arterial problem, there's no blood flow. So all these ulcers are forming. We also like to do a good palpation of our peripheral vasculature. So what temperature is it? We need to palpate the pulses. So we usually palpate the radial and then the two pulses in the foot. So the dorsalis pedis and the posterior tibial. And usually normal is going to be about a 2+ pulse. That means you can feel it pretty easily when you put your hands on it. It feels pretty regular. It doesn't, and the regularity of it doesn't necessarily matter. This is really talking about strength. But, effectively, if you're having to kind of feel a little bit, or you're having to push a little bit harder in order to feel it, or it's kind of really faint, that's more of a weak pulse. You may even need a Doppler to feel some people's pulses. A bounding pulse means you have your hands on it, and it is super strong. It literally kind of almost feels like your fingers are being pushed up. So that's what a bounding pulse is, where it's incredibly strong. We also want to do a good capillary refill assessment. This should be less than 3 seconds. And that indicates that there's perfusion getting to those capillaries. Remember all that capillary fun stuff we talked about? That's where all the magic happens, where all that, the oxygen gets to the tissues and things like that. So we want to make sure that our capillary refill is less than 3 seconds, that it's not taking a whole lot of time for color to return to the toes and to the fingers. We also want to look at edema. Is it pitting or non-pitting? And pitting means, you put your finger in it and your fingerprint stays there for a little bit. And we usually rate this, whether it's pitting or non-pitting, we rate it on the scale of 1 to 4. And 1 is trace, which means there's some. Mild, there's just a small amount. Moderate, obviously, is getting a little bit worse. And then severe is, that edema that's really not going away. It's extremely pitting edema, which means you put your fingerprint in it and it's staying impressed there for multiple minutes, or it's also just the amount of swelling, like how swollen something is. So here's some examples. So you can definitely see that pitting edema there on the left. And then you also want to know, when you're looking at edema, is it bilateral? Is it one leg? Is it 2 legs? Because this can tell us a lot about what the patient is experiencing. So there's a couple of cardiac labs that we'll definitely be discussing more later, but we always want to think about how the cardiovascular system fits in a whole and how we're going to diagnose some of these cardiovascular conditions we're talking about. So when we're talking about MI and someone having an acute coronary syndrome, we're going to be looking at cardiac biomarkers. These are going to tell us about damage to the heart, so our troponin, our CKMB. If a patient's having a pump problem, so they're having problem with, heart failure or cardiomyopathy, those structural disorders as well, we may want to be looking at BNP. Is there an excess stretch or fluid on the heart? Are they backing up full of fluid? It's also important, because the blood vessels are so intertwined in the cardiovascular system, to look at your lipid levels. Do they have excess fat or cholesterol in their blood? What are their HDLs, their LDLs, their triglycerides, their total cholesterol? And other labs we might look at are CRP and ESR, which are inflammatory labs, especially in things like pericarditis, things like that. We want to really see, is there an inflammatory process going on? Those labs alone can't tell us that, but they definitely can be helpful in that process. Again, remember how important that heart function is to kidney function. So we do want to do kidney function testing to see if our problems of the heart may be affecting the kidneys. And of course, electrolytes can lead to dysrhythmias, So we definitely want to be monitoring electrolytes, because those can so easily affect the heart when they become abnormal. There's also some diagnostic tests that we can do. So for example, chest x-ray, we can look at how big is the heart? Is it in the right place? There's electrocardiogram, and look at those first couple words, electro. So this is for electricity. So this is an EKG. And so this is going to tell us if the heart is getting perfused, so if there's a heart attack, and it's going to tell us about what rhythm the patient's in. There's also 2 types of echocardiograms. When you're looking at echo, this is actually like an ultrasound of the heart, and this is going to tell us, is the heart pumping? Are the valves working? How much blood in the heart is able to get out? So this actually can measure our cardiac output, and also can tell us if there's any infection like endocarditis, things like that. So there's 2 types. There's TEE and TTE. And the one that's at the bedside, where they're just doing an ultrasound on the outside, is a TTE, a transthoracic echocardiogram. There's also a TEE, so if a patient's in surgery, maybe have an open heart surgery, other things like that, they can do a TEE, which is a transesophageal echocardiogram. And that's going to be able to actually look, they stick a scope down into your esophagus, and they can look at your heart through your esophagus. Pretty cool, right? There's also stress testing. So what happens when your heart gets stressed? I'd love to see what a stress test looked like for all of you guys right now after watching this lecture. Probably pretty bad. There's also things patients can wear at home, like Holter monitors or loop recorders, to see if they're having abnormal heart rhythms when they're at home. We can also kind of see if a patient's ready to go home, how well their basic cardiac function is, by doing a 6-minute walk test. Can they tolerate breathing, walking at the same time? And then to look in the legs, all those leg problems that can happen with the blood vessels, we can do venous ultrasounds, see if there's a clot present or if there is blood flow present as a whole. Maybe if they're having an arterial problem, they may have lost blood flow to their legs. So these are two chest x-rays, and which one is normal? So the big difference between these two is that heart on the left is huge. Look how big that heart is. There's barely room on the left side of that patient's, or the left lung on that patient, because that heart's so big. So this is one of the ways that we can use a chest x-rays. We can really be looking at what size is that heart. Is it huge? Because remember, the heart gets big when it's trying to build up its muscle when it's not pumping well. The heart thinks like, hey, if I'm not working well, if I get big and strong and fit, then I'm going to be, really more efficient. But the thing is thick heart wall tissues, it's kind of like that tissue in ARDS, like that we talked about, that when it gets real thick and it gets real stiff, and so it's not able to squeeze as effectively. So a big fat heart is not a good thing. So here's some of the other things we talked about. They're up in the upper left-hand corner is an electrocardiogram. There's some loop recorders and Holter monitors here. You can see this woman who looks like she obviously does need her dysrhythmias checked here in the middle. And then on the right is a TTE, where's the transthoracic echocardiogram. And then at the bottom right, there's a stress test being done. There's also a variety of cardiovascular procedures. So there's a cardiac catheterization, which this is really a general term for a procedure where they inject dye and they're visualizing the heart structures. They can just look, but they can also perform interventions, putting stents in, opening, doing a balloon angioplasty, things like that. We're going to talk more about those. Coronary angiography is specific, where it's going straight to the coronary blood flow to diagnose and do the blockages specifically related to heart attacks. There's also EP studies or electrophysiology studies. These are going to look at the electrical system of the heart and diagnose or treat abnormal rhythms. And then there's also cardiovascular surgery, valve replacement, CABG, femoral popliteal bypass, or IVC filter placement. I've got some pictures of these, of course. So here is a picture of someone who gets a stent put in, and you can see that once they got the stent put in, there was the lack of blood flow on the left, and you can see now they have restored blood flow to the the rest of their heart, and you can see how much that has helped them. Just in the dye, you can see there's a lot more blood flow to those vessels below. You can, this kind of shows some of the other procedures. You can do the electrophysiology studies. This is a a cath lab, where they're doing these procedures. This is pretty much coronary angiography, where they're going in and they are trying to either assess or do interventions to help the heart. And so this in the lower middle is really showing what they do sometimes to look at, to do ablations and things like that if someone's in an abnormal rhythm. Sometimes we can actually literally burn the electrical pathway that's happening, that's not working, and try to create, to hopefully so that the heart will create one that actually works. So we'll talk more about that when we get to dysrhythmias. So a couple other things, this IVC filter, we talked about that with the pulmonary embolism here in the center. Here's some valve replacement things. So this like an open valve replacement. This is the transcatheter aortic valve replacements, which we'll talk about on the next slide. There's also up here in the upper left, this is a CABG surgery where they, pretty much create a bypass if you have a blockage, to one of your coronary arteries. We create like a new pathway to get good blood flow to your heart. And down here in the lower left is a femoral popliteal bypass. Again, this is a bypass. So there's some blood vessel that's not working, doesn't have good blood flow. So we are bypassing it and creating a new pathway for blood flow. So a couple last cardiovascular procedures, valve replacements like we talked about that can be open, which is very similar to a CABG or open heart surgery, and we're going to talk all about that. There's also the TAVR, which is the transcatheter aortic valve replacement in that upper left, which actually goes completely in your blood vessels, so they don't have to break open your sternum or do any of that really serious stuff, and they can go through the blood vessels to put that new aortic valve in. There's also going to be, when we talk about pericarditis, cardiac tamponade, there's pericardiocentesis. It removes fluid from around the heart, where they go in and do a needle aspiration. And there's also a procedure called a pericardial window, which is where they create an opening in the chest wall in your heart to allow for fluid drainage, and usually a drain is placed. So those are all very serious things that hopefully, knock on wood, that you never have to experience yourself. But we are going to talk about a lot of these more in depth in relation to the disease process it pertains to. So that's all I got. I hope I kept you entertained and got you excited for the fun world of cardiac that is to come.